Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Professor Max Edinburgh from Germany. Professor Max Ettinger is a professor of orthopedics at the Department of Human Medicine at Oldenburg University in Germany. Before joining the University of Oldenburg, Professor Ettinger taught, researched, and practiced at the Hanover Medical School in Hanover, Germany. Professor Ettinger studied and earned his doctorate at the Hanover Medical School in 2011, after which he also worked there mainly in the orthopedics department. After completing his specialist training, he was appointed consultant. In 2017, he was made head of the computer assisted surgery section and also took over as the director of tumor surgery department the following year. Professor Ettinger is an expert in knee and hip endoprosthetic reconstruction. His research focuses on the use of digital technologies and the use of robotic assisted surgical tools for improving healthcare. If you've noticed, Professor Ettinger has delivered a lecture on our channels in the past and has already reached a huge audience. And today is my great honor to bring back Professor Max Ettinger for this wonderful live program. Over to you, Max.
Hitesh, thank you very much. It's an honor that you invited me again. I always enjoy this wonderful format, and congratulations to you for developing this platform and make it free for everybody worldwide. It's really a nice tool. Today's talk is about individualized total hip arthroplasty using the coronal plane of the hip classification system. As well as for knees, the reconstruction of the hip is really important to make it individual because biomechanics is basically driven by the patient's individual anatomy. Back in the days, when you looked at the proximal femoral anatomy, you were driven by the door classification, as you see here. Everybody knows that. So, door classified three types of proximal femoral anatomies. Door 1 is the small, thin one. That's what you see here, the champagne fluted proximal femoral anatomy. Door B is basically the usual regular anatomy of our patients. And then door C is what we call stovepipe femur, so a wide canal. But that classification is not enough in order to reconstruct the proximal femur as close as possible to the patient's individual anatomy. There's more. So total hip arthroplasty really demands the reconstruction of the joint biomechanics. And as we said before, the door classification is just one out of three basic things that we need to consider. The second one is the femoral offset. All of us know that reconstructing the femoral offset is really important for not limping, for good power of the gluteus medius, as well as dislocation. And then, of course, the femoral neck anatomy is playing a big role in how easy it is to reconstruct the patient's individual anatomy. When you look at the CCD, so the caput column diaphyseal angle, so the femoral neck angle basically, we have in about 8% coxa vara. That's what you see here. 80% is coxa norma, and then about 11% have a coxa valga. When you look at the distribution, here we analyzed about 2,500 cases. You will see that basically the CCD has a mean of 130.1 degree in a Caucasian mid-European cohort, and we have a wide range from supravarus to supravalgus. When you define the hip morphotypes and basically classify a matrix of the door classification and its relation to the CCD angle, which I just showed you, you can classify the proximal femur into 9 types. So you have door A combined with the coxa vara, door A with the norma, door A with the valga, and so on. And based on that, you can have 9 boxes as you see here. One more thing, which is really important, is that door and CCD are only 2/3 of the game. And as I said before, the femoral offset plays a role as well. And you know that we have hips with high offset and normal offset, and you can basically define that high offset group with a cutoff, which is the mean added by one standard deviation, as you see here, once again, out of that cohort of 2,500 people. And out of those three things, door classification, CCD, and high and normal offset, we classified the coronal plane alignment of the hip classification here in Journal of Arthroplasty at the beginning of the year. So we had colleagues from the US within the group as well. And this is basically how it looks like. So you have door A, door B, door C. You have coxa vara, norma, and valga. And then you have N for normal offset and H for high offset. And when you put that into a matrix, you will see that the green dots are the ones with the high offset, um, and the gray dots are the normal offset. You will see that there is nothing like coxa valga combined with the high offset, which is logic, but the rest is there. So when you then keep in mind how modern stems are designed, we see that approximately 80% of the femoral anatomies might be reconstructed with stems off the shelf. But we'll discuss that later. And we'll discuss later what are we going to do with the rest out of the box. The second step of that study that I was just showing you that we did is we classified the coronal plane alignment of the hip classification, and then we were templating different stem types over that classification, straight stems, triple tapered ones, choroid stems, and short stems. And what we saw within that templating study is, and we're not going to go through that sheet here, but the short stem is basically the stem that allows us to reconstruct the patient's individual anatomy in basically most of the cases. So within that CPAH classification, a short stem is able to reconstruct about 83% of the anatomies when we talk about center of rotation, leg length, offset, and so on. But how can we achieve optimal reconstruction using the CPAH classification? And today I have some cases for you where I will show you basically how it works. So let's start with the easiest case and the most common hip, which is out there in Europe at least. So it would be nice to have colleagues from India, for example, to basically take that CPAH classification and see how the Indian population differs from the Caucasian one, for example. But once again, CPAH 5N is this standard hip, and that's the most easy one to reconstruct. So in this case, you see that with that type of stem, anatomic short stem, you are able to keep that patient in the box. So it's a door B, coxa norma, and a normal femoral offset. And of course, that's the easiest one to reconstruct. Case 2 is a CPAH 8H, so it's a door C coxa norma with the high femoral offset. Not so easy to reconstruct, but with this stem and the ability of the surgeon to play around with the neck cuts, so leave a little bit more neck and make the stem go calca guided into the canal, you are able to reconstruct the anatomy here one on one. Another case, a tougher one, you see door A, so really thin canal combined with the coxa valga and a normal femoral offset. And in those cases, you can go what we call fit and fill. So you reconstruct the patient's individual anatomy easily with the calca guided stem here as well. You can do that easily by playing around with the osteotomy of the neck. Last one, really tough as well, is a CPAH 1H. So it's a door A. So really hard to anchor for the stem, a coxa vara with a high femoral offset. And in those cases, you are able to play around with the neck cut once again. You do a really lateral cut back here in order to reconstruct the anatomy. I will show you basically how that works practically in a video that I made for you. So what we do is we define our CPAH type prior to the operation and then do a digital templating as you see here. So we have three different stem types available to basically catch most of the CPAH anatomies. In this case, it's the anatomic short stem that you saw a couple of minutes ago already. So we do the digital templating and the cup positioning. In this case, I used an anterolateral approach, minimal invasive anterolateral approach. So there's the glute medius, where I put that retractor here just behind the neck in order to preserve the anterior fibers of the glute. Then I use my fingers to basically um, clear the capsule, use a retractor anteriorly on the acetabular rim. There's the femoral neck already. You see no bleeding. You are really nice in that interval. So there's the neck. Then open up the capsule. I do it T-wise, as you see here. I resected. I never reconstructed afterwards. It's not necessary, in my opinion, in this approach. And then we move on, take away the medial part of the capsule, as you see here, put in the retractor, and then I don't dislocate the joint. I will just take the saw and cut off the head just below the head. So I will keep up the whole neck and do a second resection later in order to reconstruct the hip. And I do that resection with respect to my digital planning. Then I use a navigation system in order to place the cup exactly as I planned it. Here I just take the deepest point. I have the size, and then I will just move on with navigated reaming. As you see here, I'm away 8 mm from the deepest point. I have inclination and anti-aversion. And when I'm done with reaming, I'm going to go and put in the navigated cup. In this case, I had a really young patient. So in those cases, I do ceramic on ceramic. I am done with the cup preparation here as well. And now we're going to move on, putting in the stem. So after recutting the neck, and you see here that in this case, I need a really high neck cut. That's what you see down here. I take the instrument and then I do the preparation for the stem. You see that it's calcar guided, so you just like slide it around at the medial part around the calcar. It's a really friendly design, so no trochanteric fractures, for example, super easy to put it in. Then you have the stem in, and then you have to check, okay, is my bone cut equal to what I reconstruct with the stem? You see that here, and then I always do intraoperative fluoroscopy in order to check my stem position and compare to my planning. So you see here that the short stem reconstructed the anatomy perfectly. The joint is stable and ready to go, and this is basically the postoperative X-ray. So by playing around with the height and the angle of the osteotomy, you are able to reconstruct basically every anatomy. What is the limitation of off-shelf implants when we have a look at the CPAH classification matrix? Of course, everything which is not around the middle anymore, but here outside is really tough to reconstruct with standard implants. And it is really important that those patients get an individual reconstruction as well, because they deserve proper joint biomechanics too. So this is a good example how it is not working. So you see in anatomy, which is like far away from the middle. So we basically have a CPAH type 3 with, of course, a low offset, but super valgus. So you have a door A and a super valgus neck, and those are really tough to reconstruct because the stem will anchor here in the canal really soon. And this is an example how it shouldn't work. So a straight stem goes into the canal, anchors distally, and the joint is basically shifted from low offset to high offset. So you transfer this anatomy from this box to this one. We need further evaluation in studies to show basically the negative effect of bringing a hip from one CPAP box to another one. But of course, everybody that does hips will see that this is not going to work. Leg length massively increased, and the problem is basically that that stem just doesn't fit to this CPAP type. So when we see that with our planning algorithm using the CPAH classification, that it doesn't work, we basically go for individual implants in certain cases. So you see here once again, that's this patient out of our study. So we have a door A canal. We have like a super 162-degree CCD, and of course no offset or a low offset. And there's no stem on the market that doesn't anchor distally that you are able to reconstruct this anatomy with. And in those cases, we do individual stems because we don't want to transfer the patients from one box to another. So we did a bilateral individual one. In this case, based on our planning, where we saw that this is not going to be good for the patient. So the key message of the using the CPAH classification is that the anatomy of the proximal femur is, of course, very individual. So we have a high considerable and anatomical variability. And really important is that we have intramedullary and extramedullary geometric parameters that we have to keep in mind. And CPAH is basically the first classification system that includes all three parameters that are important for the proximal femur. The clinical relevance is that we have a comprehensive radiologic classification system of the femur in the coronal plane, of course, that's the big limitation. And for total hip arthroplasty, the reconstruction of the individual CPAH type throughout appropriate implant selection is really important. We have stems that expand the range of anatomical reconstructions. So there is not that one stem on the market that allows you to reconstruct every single anatomy. And the identification of complex cases with a mismatch between native anatomy and implant geometry is the key in order to keep our patients happy and stable afterwards. And now I thank you for the attention.
Thank you, Max. Yeah, thank you, Max, for this crisp presentation. Yeah, and it's short and sweet. I mean, you have conveyed the message. Let's take a few questions, Max.
Yeah.
Now, just one question. Did you get inspired from the CPAC?
Exactly. So I was sitting one day in the OR applying CPAC, and then I thought to myself, hip is the more successful operation, right? So we have higher satisfaction rates, but not everything runs perfect. And in most of the times, when a hip is not perfect, the joints biomechanics is not reconstructed. And then we were sitting down and saying, okay, in the coronal plane, we have those three parameters that are super important to consider, right? So we need to reconstruct the offset, we need to reconstruct the CCD, and we need proper anchoring, right? And out of those three parameters, we basically developed that classification matrix in order to make it a little bit more comparable what we talk about. So for further studies, it is really easy now to say, okay, in a CPAH type, whatever, stem whatever works better than stem XYZ, for example. And that's the most important thing, that we will be able to compare things easier to each other, which is the main benefit of CPAC, that it is simple and definitely not 100%, but we have a baseline to start from. And that's basically what our thoughts were on this.
Thanks, Mac. And interestingly, when we did the CPAC, at that time, I had no idea what you're talking about. But over a period of time, I read again and again about CPAC. And then I can see all people are discussing in all the meetings about the CPAH classification. So I'm sure CPAH is also going to get incorporated into routine orthopedic literature, because what you said is there's high satisfaction in THA, but there are some technical issues, right? So that is a problem with THA rather than the satisfaction. And just for the
Yeah.
benefit of audience, Max, so we need to consider the offset, we need to consider the neck shaft angle and the door canal geometry, right? These three factors.
Exactly. And the most important thing, which is going to come probably more into the conferences and stuff, is the anterior offset. So in this case, we talk about lateral offset, but anterior offset is going to be super important as well in the future. And you basically reconstruct the anterior offset automatically when you basically don't cut the whole neck away, let's say it that way. And if you have stems that go in the direction of the natural neck version, you automatically reconstruct the native center of rotation by taking the natural neck version, for example. And I think it is really important to, and this is why I brought those examples, playing around with your neck cut with modern implants is probably what's going to bring the total hip arthroplasty on the next level, right? And when you look at the newer stems that all of the companies are bringing, they are all shorter, all anatomic. Some have a collar, some not. That's another discussion. But you are able to basically some sort of take the natural version of the neck, and that classification matrix basically gives you really a hint on where to cut. Let's say it that way. Yeah.
And yeah, Max, thanks for that. And this is ideal if you're thinking about using a short stem, right?
So what we did is we did a planning of all of those cases, and with the short stem, you are able to reconstruct about 80% of all CPAR types. Of course, the short stem is not always the solution, right? So, for example, in a CPAR type where you have a door C anatomy with a low offset or whatever, you can use a straight stem, for example. So it's not that a triple taper or a straight stem is always worse than a short stem. But that is exactly what that classification matrix is there for, because you can really template through the box, and then you see, okay, which stem is the best for reconstructing that individual box. And this is why it's so important that you have basically different stems on shelf. To do that, there is not that one stem the same. There's not that one knee that basically reconstructs every single anatomy good. So, for example, I have one of those modern collared stems. I have a triple taper one, and I have a short stem. And with that, I'm about, let's say, around 95% of anatomies that I can reconstruct. And then in certain cases, you have to do an individual stem in order to reconstruct the anatomy. If it's weird, as I showed with like a CCD of 162 or whatever, there's nothing on the market that really helps you with that. So that classification system basically gives you an overview which stem is basically fitting to my patient's individual anatomy. And um, let's say 15 years ago, people were saying, okay, a short stem is something good for a young active patient or whatever. I don't care about age and stuff like that. I only care about anatomy, and that's what I want to reconstruct. So if the stem fits to the anatomy, that's basically what you want to do.
And Max, this classification is ideal when we do a computer navigated THA, right? What about the conventional THA? Are you able to pre-op determine exact CPAS subtype?
Yeah, it is not. It's not mandatory to have some sort of navigation or whatever. As you saw, I do my femoral preparation 100% manual. There's no technique in it. But you really have to focus on what did I plan and how much bone do I want to take away, and how steep is my osteotomy going to be. I use navigation on the acetabular side because I'm faster with that, bringing the cup exactly where I want it. but that has nothing to do with the classification system. It's totally independent. So you can do it with a digital templating tool everywhere in the world. No problem.
You're the first person reporting on the CPAH, right? This classification.
Probably,
Ricardo
yeah.
Strauss, if I'm right, is the first author.
She's one of my residents. So we
Okay,
developed
so you guys are
together.
the first to describe the classification, kind of.
Yeah, together
And
together with Thorsten Seiler from Duke and Michael Mont from Mount Sinai Hospital, and then Peter Savov, who's working with me as well. Yeah, so we were basically working on that for the last 4.5 years. So it's really hard. So we did the study, the templating and everything without AI. So it was like manual templating, manual measuring of 2,500 cases. So it took a while. From the idea to the end, it took a couple of years.
thank you, Max. Always revolutionary. I mean, because I really enjoyed the CPAC classification those days, and only recently I could really comprehend what exactly it was. But I think this is much easier, right? Since you have come from that, I think this is more easier to comprehend, and I'm sure it's going to benefit a lot of people, Max.
It would be really nice if you could encourage some of your colleagues from India to just like make a study in the Indian population.
Yeah, sure.
But what I really enjoyed was when Samek Desi and Darren Chan and Johan Bellemans came up with CPAC, that you had all of those papers, how different the anatomies based on CPAC are in India, in China, and whatever. And
Different
that
parts of
really
the world.
yeah, totally different and totally interesting. So it's like a total difference between like a mid-European cohort and, for example, Japan or India, right? So and I think that's really interesting to see because, for example, the varus knees that you have in India, that they are so rare in Europe, for example, and we just didn't know. And from looking into that studies, you sort of know, okay, now we know how our Indian colleagues are feeling every single day,
Yeah, you know
So
what? I was presenting on total knees at one of the meetings last year in Croatia, and some of the virus knees I presented like they were like, "Oh my God, we haven't
yeah,
seen them."
yeah, super rare, right? So
Fair
we
enough.
try to define a new, let's say, baseline that we can do research all over the world and basically have a baseline to start from and discuss. So
Thank you, Max. I think that's all the questions that we have for the session, and we really look forward for more from your side, especially on the computer assisted part. Loy, you're late to the show. We just
Hello,
winding up.
sorry,
Any
sorry,
pertinent
guys.
questions? I think Loy was on
Can,
another program. Sorry about it. Loy, your
yes,
questions to Max, if in case you have listened to it. The new
yeah,
classification, the CPA, is developed with Professor Michael Mont as well.
yeah, excellent. Can you hear me, guys?
Yeah.
yes, we can hear you.
Yeah, excellent talk, Max. I think this is the door plus classification. Maybe one of the questions that may I ask you: do you need really a CT scan? Do you need really a CT scan in order to achieve this classification that will enable you to classify which SEPA is? You know that, as you mentioned, SEPA is about this is about stem anatomy and proximal
Yeah.
femoral anatomy. So there will be inter-observer variation between one surgeon to other. Is it recommended to use a CT scan before you go further with this classification? And this is my first question. Second one, would you still apply it for dysplastic hips, post-traumatic arthritis, and these types of hips? And maybe one of the things that was thinking about, if you use this classification, use your STEM, would that affect the outcome? You will have a better outcome, better STEM survivorship, clinical outcome will be better. What do you think?
So CPA based on CT will be CPA 3D in a couple of years. Definitely that is something that we have to look into and bring it into the next dimension. We discussed anterior offset and stuff like that. That's probably something that needs to be included. But for the beginning, it is a great help to basically go through different stem types and template them through that you are more or less able to reconstruct the patient's individual anatomy and combine that with proper implant anchoring. That is really important as well. And when you ask me if it makes a difference clinically in the future, my answer is definitely yes. So when you looked at that one example that I brought, that CPAH door A valgus case, if you lengthen the leg by 2 centimeters and you increase the offset, that patient is definitely going to be unhappy. And in the future, we're going to talk about, okay, transferring a hip from one box to another is probably going to be something that's going to decrease your clinical outcome. And by that, probably decreasing the survivorship as well. But we are in an early phase, so all of our studies comparing different stems and outcome and stuff like that on hip from my institution and from Thorsten Seiler from Duke, for example, we will rely and refer back to CPAP from now, because then we can say, okay, in the group where we have the dissatisfied patients, we transferred the group, and so it's going to be basically a baseline. Same as for CPAC, right? In the beginning, it was just a pure description of different angles and how they relate to each other. And now we have studies coming out. Okay, if you transfer a CPAC 1 into a CPAC 5, your outcome is worse instead if you're just going to keep it in a CPAC 1, for example. And that is basically what we hope is going to evolve out of this matrix.
Awesome. Best of luck then.
Loiy, any more questions?
That's it. That's it. Thank you. Thank you, guys.
Thank you so much, Max. I think that's all the questions that we have. And Loiy, Max also does a lot of tumor resections, and we are looking forward for a tumor surgery talk, because that is unique to Oldenburg.
We will do that, and probably maybe in September or October, we will see back each other, and then we're going to talk about tumor resection principles.